How is the perineurium important to COVID, IAC conditions, infection-associated chronic conditions, dysautonomia, and cancer? In this short YouTube, we will review the importance of the perineurium and its component cells, which are known as perineurial cells, in these pathological states. First paper from 2022. SARS-CoV-2 entry sites are present in all structural elements of the human glossopharyngeal and vagal nerves. Clinical implications. Findings. All three of the proteins, ACE2, NRP1, and TMPRSS2, required for SARS-CoV-2 infections, appear to be present in all cellular components: Schwann cells, axons, vascular endothelium, and connective tissue of the human 9th and 10th nerves near the medulla. The 9th cranial nerve is the glossopharyngeal nerve. The 10th cranial nerve is the vagus nerve. We also found mRNAs for these proteins in the nerve and in human oligodendrocytes and fibroblasts, which were stained by antibodies directed at all three proteins examined. Interpretation. Infection of the glossopharyngeal and vagal nerves by the SARS-CoV-2 virus is likely to cause the loss of taste experienced by many COVID patients. Migration of the virus, CoV-2, from the oral cavity through these nerves, cranial nerves, to brainstem respiratory centers might contribute to the problems that patients experience. Important background for this paper. Perineurial glia, a review from 2015, and a more recent paper on motor exit point glia. These are the glia that give rise to the perineurium. They are a novel myelinating glial cell type that bridge the central nervous system with the peripheral nervous system. Back to the 2022 paper, figure 6. We're talking about how COVID infections of the oral pharyngeal cavity, including the tongue, the pharynx, and epiglottis, can infect neurons which are collected into various cranial nerves: the 7th nerve, the 9th nerve, and the 10th nerve. Shown in the figure are the ganglia, which lie to the sides of the brainstem: the geniculate ganglion, the petrosal ganglion, and the nodose ganglion. The nodose ganglion is one of two ganglia that compose the vagus nerve. This is where the cell bodies for the vagal nerves are located. The illustration on the left shows where respiratory nuclei are located. Now, nuclei in the context of neuroanatomy refer to a cluster of cell bodies of neurons, and that is termed a nucleus. So in some cases, the cluster of neurons are referred to as a nucleus, and others they're referred to as a complex. These complexes, brain nuclei, are interlinked into a connectome. In this case, the function is to integrate signals from peripheral organs which mediate respiratory function. The activity of this network is to control respiration and to modulate it in response to physiological needs, including sleep. Viral infections of cranial nerves that innervate the brainstem, or the infection of the brainstem itself by viruses, are likely to have major impacts on the integration of signals coming from respiratory organs. This is likely to disrupt the cranial reflex arcs, which are being integrated in the brainstem, controlling the activity of respiration. So before reading the figure legend, I would like to discuss the illustration on the left-hand side of the figure. So reading from top to bottom, from the pons to the medulla, various nuclei, which were referred to as groups or complexes. Again, these are clusters of neuronal cell bodies, and these nuclei are interconnected by axons and synapses. So we're starting with the dorsal respiratory group. Dorsal refers to the back side of the body. Butzinger complex, this is a respiratory complex. The pre-Butzinger complex. The rostral ventral respiratory group. The caudal ventral respiratory group. And down in the medulla, the brainstem, there are motor neurons which innervate the diaphragm. These motor neurons emerge from the neck at cervical vertebrae 3, 4, and 5. They are bundled together in the phrenic nerve, which innervates the diaphragm. Now, with that background, I would now like to read the figure legend. Schematic drawings of the cranial nerves in our study and their connections in the brainstem. Panel A, which is not shown in this slide. A schematic drawing of a human nerve bundle shows possible membranes and spaces where the virus can potentially move along the nerve. That was shown earlier in this YouTube. Panel B shows a simplified version of the brainstem from a dorsal view, not indicating the dorsal ventral depth, where the solitary tract, also known as the nucleus tractus solitarius, NTS, where the solitary tract neurons receive input from the periphery, from the ganglia of the 7th, 9th, and 10th cranial nerves. And again, the ganglia associated with those nerves are the geniculate ganglion, the petrosal ganglion, and the nodose ganglion of the vagus nerve. The right side shows the intimate closeness to the neurons of the pre-Butzinger and Butzinger respiratory complex and other respiratory centers, including the cells innervating the phrenic nerve, that could potentially all be harmed by viral invasion through the cranial nerves, including but not restricted to the gustatory fibers, the taste fibers. The small inset shows a sagittal schematic of the medulla to demonstrate how close the dorsal respiratory group, colored gray, is to the NTS, the nucleus tractus solitarius. These two nuclei are labeled with a red arrow in the figure. Now I've added additional red arrows over on the right. These indicate viral infections, a primary COVID-2 infection infecting the tissues of the tongue, the pharynx, and/or the epiglottis, and the potential transactivation of dormant herpes simplex virus 1, HSV1. So takeaway concepts, there are potential sites for COVID-2 tropism in the peripheral nervous system non-neural cells. So these would be in the cranial nerve. They're non-neuronal components. Particularly, we're going to discuss the glial cells of the perineurium. That's coming up in later slides in this YouTube. So as COVID-2 infects neurons, it can also potentially infect glial cells, which are in close proximity to neurons. And what we will discuss is new evidence, well, it's actually from 2010, an animal model, that shows that HSV1 can infect perineurial glial cells. So there is a reservoir, a long-term reservoir of HSV1 lying dormant inside nerves that have been infected earlier by HSV1. And a common theme, which was discovered early in the pandemic, was that CoV-2 is capable of reactivating dormant viruses, particularly herpes viruses, such as herpes simplex virus 1 and Epstein-Barr virus. And this dramatically changes the chronicity of the COVID infection, can prolong it and expand its dimensions. And what we're discussing here is how CoV-2 and or the reactivation of HSV1 could be impacting the brainstem and thus affecting functions like respiration. Now, sidebar comment on the phrenic nerve, which receives motor neurons from cervical levels 3, 4, and 5 in the neck. The phrenic nerve is a critical mixed motor and sensory nerve originating from the cervical spinal cord levels C3, C4, and C5. These refer to the nomenclature of the cervical vertebrae. There are 7 cervical vertebrae in the human neck. Its primary function is providing motor innervation to the diaphragm. This is the phrenic nerve, making the phrenic nerve essential for breathing. The origins of the phrenic nerve are famously summarized by the medical mnemonic. C3, 4, and 5 keep the diaphragm alive. This is a compact way of remembering that these cervical nerves, cervical neurons coming out of vertebrae 3, 4, and 5 in the neck are essential for controlling the diaphragm. So question, are cranial nerves organized like spinal reflexes? The answer is yes, as both follow the exact same foundational principle of automatically converting a sensory stimulus into a motor response without requiring conscious thought. And that is very important for respiration. The integration of signals coming from various sensory organs, which include the tongue and the pharynx, as well as the lungs and the diaphragm. These are integrated in the brainstem as analogous to spinal reflex arcs. However, the interconnections between various levels in the brainstem, that is more complex than you find in the spinal cord. Infection and inflammation of cranial nerves and or the brainstem is likely to alter the connectome and thus the sensory motor functions of the brain. We have been focusing on breathing, but it's important to recognize that the brainstem is carrying out many autonomic functions simultaneously. The nucleus tractus solitarius, NTS, is the primary sensory integration center in the brainstem for all visceral information. The nucleus tractus solitarius acts as a master relay station, collecting taste signals and internal bodily feedback to manage vital homeostatic reflexes like breathing, heart rate, digestion, and the gag and vomit reflexes. When cranial nerves become infected by viruses, and in some cases when these infections pass into the brainstem, the integration of these visceral functions is going to be disrupted. And the nucleus tractus solitarius will be then exporting aberrant signals, leading to aberrant behaviors, excessive gagging, excessive vomiting, changes in breathing, sleep patterns, altered digestion and heart rate. In the past, neurologists have interpreted some of these symptoms as being psychogenic because they are being integrated at supraspinal levels, above the level of the spinal cord. And yet, these autonomic reflexes are primarily integrated in the brainstem, but they affect conscious behaviors as well. People avoid certain stimuli which trigger them to gag or vomit, or they have sensory inputs that trigger autonomic responses. Collectively, dysfunctions in autonomic reflexes fall into the category of dysautonomias. And dysautonomia is a broad bucket concept which is now at the center of IAC conditions, infection-associated chronic conditions, including long COVID. So, in short, I would like to summarize the complexity of this figure in the following takeaway points. There is potential CoV-2 viral tropism in the peripheral nervous system in non-neuronal cells, non-neural cells, glial cells. There is also potential HSV1, herpes simplex virus 1, transactivation in peripheral nervous system non-neural cells, glial cells. CoV-2 and or HSV1 neurotropism is likely to impact cranial reflex arcs and integration. A sidebar comment. Some people would refer to neurotropism as only growth of a pathogen, in this case a virus, inside neurons. Other neurologists and neuroscientists would consider neurotropism to indicate growth of a pathogen inside the nervous system, whether it's central nervous system or peripheral nervous system. To distinguish neurons from non-neuronal cells, the term glio as a prefix to tropism can be included. And I would like to do that here. I have studied glial cells for 40 years, and glial cells are highly neglected in terms of their roles in pathology. So I think it's very important to introduce the term gliotropism into these discussions, particularly in the latter parts of this YouTube. So the takeaway concept of this slide is that CoV-2 and or HSV1 gliotropism is likely to impact cranial reflex arcs as well as their integration in the brainstem. And that takes us to this paper published in 2010, a seminal paper which should guide immediate and long-term study into the roles of gliotropism, particularly of the perineurium. This paper, Influence of Perineurial Cells and Toll-like Receptors 2 and 9 on herpes simplex type 1 entry to the central nervous system in rat encephalitis. The authors of this paper studied HSV1 infection in two types of rat strains. One was a highly inbred strain known as the DA strain. DA rats is an abbreviation for dark agouti rats. So just a quick read through the abstract. The virus distribution and the immunological responses were compared in the whiskers area where the virus was injected, trigeminal ganglia, and brainstem after 12 hours and the first 4 days following infection using immunohistochemistry and quantitative reverse transcriptase PCR. A conspicuous immunopathological finding was a strain-dependent difference in the spread of herpes simplex virus 1 to the trigeminal ganglion, only seen in the DA rats, already from 12 hours post-infection. Our data demonstrate the novel observation that genetically encoded properties of the host nerve, i.e. the trigeminal nerve, and its perineurial cells recruitment of phagocyting cells, macrophages, together with the low expression of toll-like receptor 2 and toll-like receptor 9 in the periphery, define the susceptibility to HSV1 entry into the nervous system. This is a summary graphical abstract of the findings. So comparing A and B, A is the inbred rat strain, the DA rat strain, which was highly susceptible to viral invasion of the trigeminal nerve, which are illustrated with the green stars. In the susceptible DA rats, fewer immune cells were recruited to the inner part of the perineurium, that is the covering of the nerve, the outer covering, which is cellular and has also strong amounts of extracellular matrix. So fewer immune cells were recruited to the inner part of the perineurium, which most likely facilitated the viral spread to the perineurial cell layer. Again, the perineurium, illustrated here, is the dark outline around the fascicles of axons inside the nerve. Those areas are more highly infected in the DA rat, its trigeminal nerve, compared to the PVG rat strain. Since the high density of phagocytic macrophages co-localized with HSV1 in the perineurium did not prevent viral replication, it cannot be excluded that these cells, i.e. HSV-infected macrophages, possibly contributed to viral spread to the central nervous system. Collectively, these data indicate the importance of early recruitment of phagocyting cells and their ability to control the infection by preventing viral spread to perineurial cells and thereby restricting propagation of the virus along and in the nerves. Stepping back from the details of this paper, there are some important general views that can be stated. First, a single pathogen, HSV1, has multiple sites where infection can take place. Also, the ability of HSV1 to establish itself as a long-term reservoir within perineurial glia is implicated by this study. When HSV1 reactivates, how does it migrate? Certainly, it is believed to move through the interior of axons. However, it is also possible that phagocytic immune cells being recruited into the nerve because of the reactivation of the virus could result in immune cells becoming infected with HSV1. So there are multiple ways that the HSV1 can move. This is the kinematics of the infection. This reactivation of HSV1 is very important because it's now believed that in elderly people, the reactivation of HSV1 is one key driver of early onset Alzheimer's. So in general, how is the perineurium important to COVID, IAC conditions, including long COVID, dysautonomia, and cancer? We need to understand these various tissue compartments of nerves, how they're impacted by viral pathogens and their toxins, as well as the inflammatory reactions that take place when immune cells infiltrate the nerve. So simply stating, the perineurium is a specialized protective sheath of connective tissue that surrounds a bundle of nerve fibers called a fascicle in the peripheral nervous system. However, this is overly simplified. It does not state that there are specialized cells that compose the perineurium, which can be infected by viruses, and how the perineurium interacts with other cell types, including malignant cells. So in the final slides of this YouTube, I would like to discuss this interaction of malignant cells with the perineurium. Draw your attention to this review from 2019, Perineurial Invasion of Cancer, a complex crosstalk between cells and molecules in the perineurial niche. The concept of a perineurial niche for a malignant cell is a relatively new concept. It is useful to incorporate into a broader set of concepts which can be referred to as invasive neuropathies, which will include both malignant cell invasions as well as invasions of viruses into the tissue compartments of nerves. So I am adapting a figure from a paper in 2009 to illustrate these concepts of perineurial niches. The first, A, shows a tumor cell in a perineurial space which lies below the epineurium, the outer tissue coat of a nerve. So the tumor cell has detached from the primary tumor and it digested its way through the epineurium to lie interior of the epineurium. Example B shows a tumor cell that has digested its way both through the epineurium and the perineurium and now lies inside the endoneurium where there is a bundle of axons, and here it is dividing and proliferating. So one can say that the tumor cell has invaded the perineurium, and this could be referred to as an example of an invasive neuropathy. Now, taking these concepts of invasions, not just tumor cells, but viruses, we've been discussing how HSV-1 can invade the tissue compartments of nerves and infect the perineurial cells of the perineurium, and that's illustrated in example C. Now, potentially, an infection like CoV-2, perhaps through inflammatory signals, is able to reactivate HSV-1 in many tissues and perhaps the perineurium. That is a hypothesis. Example D shows the invasion of a rabies virion invading axons in the endoneurium. Once again, the endoneurium is the tissue compartment of a nerve which contains a fascicle, a bundle of axons, and certain viruses are able to move within the cytoplasm of individual axons via microtubule-based transport. So these concepts can be folded into a loose term, relatively new, which can be referred to as invasive neuropathy. The term invasive neuropathy is not standard medical diagnosis. It generally refers to cases of severe, rapidly progressive, or treatment-resistant peripheral neuropathy, often caused by autoimmune diseases, tumors, or direct nerve entrapment, where nerve damage invades normal function, resulting in chronic pain, sensory loss, and muscle atrophy. All of these symptoms, concepts, are likely to be applied in IAC conditions, including long COVID. So the term invasive neuropathy also has the utility of emphasizing the fact that certain viruses can invade different tissue compartments of nerves. And that's what we're discussing in the context of COVID-2 infections. Now, a current definition of perineurial invasion in the context of tumor cell invasions of nerves is found in this 2023 paper, Perineurial Invasion, PNI, definition. Histopathological parameters of PNI in oral squamous cell carcinoma with molecular insight and prognostic significance. Perineurial invasion in cancer refers to tumor cells spreading along or inside nerve sheaths. Diagnosed via microscopic pathology, it is recognized when cancer cells are found with any of the three layers of the nerve sheath, the epineurium, the perineurium, and the endoneurium, or when tumor cells encircle at least 1/3 of the nerve circumference. So the concept of perineural invasion could be applied to viruses as well. And examples C and D show HSV1 infecting the perineurium, C, and rabies virions invading axons in the endoneurium, and that's example D. So the concepts of invasive neuropathies can be applied to viruses. And here, this paper from 2025 discusses neuroinvasion via peripheral nerves in epidemic viral encephalitis caused by enterovirus, orthoflavovirus, and SARS coronavirus. Note that they're emphasizing the pairing of neuroinvasion via peripheral nerves, because neuroinvasion generally means invasion of the nervous system. Here they're distinguishing the peripheral nervous system. Abstract. Pathogens invade the central nervous system and cause infections either through the hematogenous route, the blood vessels and lymphatic vessels, or via peripheral nerves. Neuroinvasion via peripheral nerves involving spinal or cranial somatic nerves is well established for certain viral encephalitis, such as rabies, herpes simplex encephalitis, and poliomyelitis. Advances in understanding emerging and re-emerging viruses that cause epidemic CNS infections have highlighted the growing importance of peripheral nerve pathways in viral neuroinvasion. This review focuses on epidemic viral encephalitis caused by three groups of RNA viruses: enteroviruses, orthoflavoviruses, and severe acute respiratory syndrome coronaviruses, mainly severe acute respiratory coronavirus 2. We examine evidence supporting the hypothesis that peripheral nerve viral transmission may play an increasingly significant, if not more critical role than the hematogenous route in neuroinvasion. In this YouTube, we have emphasized that it is now known that HSV1 can infect cells of the perineurium in a rat model of HSV1 infection. Therefore, it is important to add the concepts of glioinvasion and gliotropism within the CNS to the analysis of neuroinvasion by viruses in general. This paper from 2021 is important to review because it illustrates the concepts of glioinvasion, innate immune signaling, and role of glial cells in herpes simplex virus and rabies virus-induced encephalitis. The inset on the lower right shows histological stains of brain tissue, brainstem tissue, of rodents that were infected either with rabies or HSV1. And there are different cellular pathologies present. In rabies, there's a small number of necrotic neurons within the brainstem, but no major infiltration of phagocytic cells. In contrast, the brainstem of a rodent with HSV1 infection, this is herpes simplex virus 1 infection, shows major inflammation. The histological section shows histiocytes, which include macrophages, resident tissue macrophages, as well as dendritic cells, which are activated. In addition, there are lymphocyte infiltrates, which have left the blood supply system of the tissue, crossed the blood vessels, and infiltrated into the parenchyma of the brainstem. So this is a major difference in the histological presentation of these viral infections. Now, above this shows in the central nervous system, the CNS, and the peripheral nervous system, PNS, where these two viruses invade. And this shows the tropism of the viruses in these various cell types of the CNS versus the PNS. In the central nervous system, herpes simplex virus and rabies virus can invade both neurons and glial cells, microglia, astrocytes, and oligodendrocytes. In the peripheral nervous system, HSV1 and rabies can infect peripheral neurons as well as Schwann cells, the glial cells that surround and myelinate axons of peripheral nerves. And in the case of HSV, it can infect satellite cells, which are glial cells that form the sheath of ganglia, such as dorsal root ganglia. So the concept of peripheral tissues, like mucosal tissues, becoming infected with viruses, then moving into the nervous system through nerve endings, being carried by peripheral nerves, including cranial nerves, into the central nervous system. This shows a neurological, nerve-based pathway for the invasion of the central nervous system. Figure 1 illustrates the two major mechanisms by which the central nervous system can be infected by, quote, neurotropic viruses. A hematogenous pathway through blood vessels or through nerves. Now, the term neurotropic viruses needs to be expanded to gliotropic viruses, because in both the central nervous system and the peripheral nervous system, as well as the autonomic nervous system, you have neuronal cell types and non-neuronal cell types. Glial cells are frequently infected by, quote, neurotropic viruses. It's important to also refer to them as gliotropic viruses. And that brings us to this paper, which was published early in the pandemic. SARS-CoV-2 dissemination through peripheral nerves explains multiple organ injury. So, transsynaptic transfer of the coronavirus needs to be considered as a means of propagating the infection from infected peripheral organs, mucosal tissues in particular, nasal epithelium, oral pharyngeal epithelium, the lung epithelium, and the gut epithelium. All of these locations are potential launch points for the COVID infection to pass from the primary mucosal infections to a secondary site, which would be the nervous system. And the idea that neurotropic viruses can move through axons, infecting glial cells along the way, is a potent conceptual framework to explain how CoV-2 can disseminate through the body as well as form persistent tissue reservoirs. Glial cells are a known site for neurotropic viruses such as HSV1 to establish persistent tissue reservoirs. In the case of a COVID-2 infection, the invasion of nerves by COVID-2 is likely to produce neuritis, inflammation of the nerves. This neuritis could well reactivate dormant HSV1, which is harbored both within neurons and surrounding glial cells. In doing so, CoV-2 is, quote, transactivating dormant HSV1, and this alters the chronicity and dimensions of the CoV-2 infection, leading to potentially long COVID symptoms and pathologies. I would now like to draw these concepts together and apply them to disorders such as long COVID and Alzheimer's disease. We have seen from this 2010 paper that HSV1 is a gliotropic and neurotropic virus. Again, reading the title and abstract from this paper, influence of perineurial cells and toll-like receptors 2 and 9 on herpes simplex type 1 entry to the central nervous system in rat encephalitis. Herpes simplex encephalitis is a rare disease with high mortality and significant morbidity among survivors. We have previously shown that the susceptibility to herpes simplex encephalitis was host strain dependent. As severe lethal herpes simplex encephalitis developed after injection of human herpes simplex type 1 virus into the whisker area of DA rats, whereas a less inbred strain of rats remain completely asymptomatic. In the present study, we have investigated the early immunokinetics in these strains to address the underlying molecular mechanisms for the observed difference. The virus distribution and the immunologic responses were compared in the whiskers area, trigeminal ganglia, and brainstem after 12 hours of infection and the first 4 days following infection. It is important to emphasize that the investigators were using human herpes simplex virus type 1. They were applying it into the whisker areas of inbred rats, which were immunodeficient to resist this herpes infection. It is important to compare this outcome to the outcome of a recent clinical paper also dealing with human herpes simplex virus 1. Calcifediol and pericalcitol as adjunctive therapies for HSV1 keratitis and corneal perforation, a case report. In this study, clinicians utilized 2 vitamin D receptor agonists to treat a woman who had a history of recurring HSV1 infections of her oral labial region. In this case, the infection had spread to her cornea, in one of her eyes. She was hospitalized, given intravenous acyclovir, the standard of care for severe herpes infections. And then through a difficult surgery, the iris was withdrawn back inside the cornea, and then the cornea was protected with a chorioamniotic graft derived from human placenta, which contains growth factors that help heal the tissue. Afterwards, the patient, being discharged a month later, began to develop herpes infections elsewhere in her body, and her cornea remained very thin where the lesion had closed. The clinicians then initiated calcifediol and pericalcitol treatment for several months, discontinuing the pericalcitol but continuing with calcifediol. The cornea thickened. There was no reoccurrence of HSV1 infection in the cornea, which was remarkable. About a year later, she was given a corneal transplant because she had developed a cataract from the original lesion. After the corneal transplant, the patient now has about 80% normal vision in this eye. So utilizing calcifediol and pericalcitol to stimulate vitamin D receptors is a means of helping to suppress immunocompromised tissues, ones that are prone to viral reactivations, in this case, herpes virus reactivations. Can this same strategy be used in other contexts, such as Alzheimer's disease? Mechanistic insights into the role of herpes simplex virus 1 in Alzheimer's disease. This graphical abstract of this review illustrates that, like many viruses, HSV1 hijacks cellular metabolism, cellular organelles, produces severe inflammation, and this is now believed to be a key driver of certain forms of Alzheimer's disease. Can vitamin D receptor agonists be used in combination with standard of care antivirals such as acyclovir to arrest and protect the brain and central nervous system from HSV1 infections in the context of Alzheimer's disease and perhaps long COVID as well? This final slide summarizes concepts that we have been discussing, particularly the use of vitamin D receptor agonists as adjunctive therapeutics to be used with pathogen-directed antivirals. What is a pathogen-directed antiviral? These drugs have been designed to interfere with enzymes or other proteins required for viral replication. In contrast, vitamin D receptor agonists are host-directed antivirals. They serve to bolster a multitude of pathways that provide innate immunity, antioxidant capacity, and the healing of injured tissues. So conceptually, there is no fundamental reason why vitamin D receptor agonists could not be combined with pathogen-directed antivirals. Another motivation for using them is that certain antivirals, such as Paxlovid and tenofovir, are known to be, quote, vitamin D disruptors. They interfere with the biosynthesis of calcitriol in the kidneys, and they can also alter the expression, upregulate the expression of an enzyme, 24-hydroxylase, which results in the degradation of both calcifediol and calcitriol, two key innate immune hormones that act in the blood as well as in mucosal tissues, such as the cornea. So just reading this AI overview, COVID-19 can trigger the reactivation of latent herpes simplex virus 1 due to the severe immune dysregulation and inflammation caused by the virus. While often manifesting as common cold sores, HSV1 reactivation can present more severely in hospitalized or critically ill COVID-19 patients, requiring targeted antiviral treatments like acyclovir. So in closing, I would like to say we now have a paper published in an ophthalmic situation, the use of vitamin D receptor agonists, calcifediol and paracalcitol, utilized in tandem with acyclovir, sometimes in tandem, sometimes in sequence. This is an example of utilizing vitamin D receptor agonists as adjunctive therapies to existing pathogen-directed antivirals. Long COVID link. Some researchers hypothesize that the persistent low-level reactivation of herpes viruses, including HSV1, may contribute to the chronic fatigue, neurological issues, and inflammation seen in post-acute sequelae of SARS-CoV-2, long COVID. Once again, draw your attention to the reference on the right, calcifediol and paracalcitol as adjunctive therapeutics for HSV1 keratitis and corneal perforation. These two vitamin D receptor agonists should be explored for the treatment of long COVID, as well as other IAC conditions.